In this set of slides, we'll be looking at post-operative nausea and vomiting. If you click on the speaker icon on each of the slides, there will be audio to support the text. If we start by defining what post-operative nausea and vomiting is. So post-operative nausea and vomiting is any nausea or retching or vomiting that occurs during the first 24 to 48 hours after surgery in inpatients. So nausea and vomiting is the most common cause of patient dissatisfaction after anaesthesia, and there are reported incidents of 30% in all post-op surgical patients and up to 80% in high-risk patients. So if we look when emesis or vomiting is good, so vomiting is our own sort of protective reflex that's there to stop us absorbing any toxins that we might have ingested. So, an example of this is if you drink too much alcohol, for example, your body doesn't want to keep absorbing the excess alcohol that's in your stomach. So what it does is it makes you sick to try and reduce the amount of the toxin that's available within your body. Other chemicals like cytotoxic agents, they can be very nausea inducing and vomit inducing. So our bodies are trying to get rid of these things as part of our protective reflexes. So you might wonder why on this page there's some pictures of Egyptian females. So if you go back and look at the history, so Egyptian history, females used to take medicines or potions that would make them sick. And this at the time was deemed to be beautiful. That was how they would almost woo their partners, because it was seen as very beautiful if you were being sick and you were vomiting at the time. So for those of you that are the girls thinking now, so next time you're being sick after excess or because you're ill, just remember to yourself that you're looking beautiful at that time. And think that you were an Egyptian lady and you are looking your most glamorous at this moment. We're going to look now at some of the complications that might be caused by post-operative nausea and vomiting. So the first one could be pulmonary aspiration. So if as part of your anaesthetic, as you're coming round and you haven't got your protective reflexes back fully, but you vomit at the time, there is a risk that you could then aspirate your stomach contents into your lungs and end up with an aspiration pneumonia. So another thing is the stress to your incisions. If you think how vigorous the vomiting process is and the vomiting reflex, your abdominal muscles are tensing. You often feel quite achy after you've had a period of vomiting. But if you put a surgical incision into this as well, that's putting a lot of strain on your surgical incision. So that's going to be very painful, but also it could break down the wound from that. So the next thing to think about is the possibility of dehydration. So the fluid that you're vomiting up has had to come from somewhere. So it's either you're not absorbing the fluids that you've taken orally, or the stomach acids have had to come from somewhere that you're bringing up. So it can lead to dehydration if you've got prolonged vomiting. But also you get an electrolyte imbalance because you've got all the hydrogen ions within your stomach acid. This can lead to electrolyte imbalances. So if people have got prolonged periods of vomiting or diarrhea or both, it's really important to keep an eye on their electrolytes because they can easily go off. So your sodium and your potassium can go out of normal range. Another thing of prolonged vomiting is that you can have injuries to your teeth and gums. So you see this particularly in people that are bulimic, for example. So because they're repeatedly making themselves sick, the stomach acid can affect the enamel on their teeth and it can rot their teeth. And you can have injury to the teeth and the gums. You can get receding gums because your mouth isn't used to the acidic environment that it it's being exposed to from the stomach acid. And this is the same for the esophagus. So you can get esophagitis, so inflammation of the esophagus. The lining of your stomach has this mucosal layer that is designed to be acid resistant, but the esophagus isn't. It has a different epithelial lining that isn't acid resistant. So if that stomach acid comes up into the esophagus, that's where you get heartburn, because your esophagus is being burnt by the stomach acid, and this can lead to the esophagitis. So post-operative nausea and vomiting is one of the most common causes of delays in discharge, particularly being the cause for conversion from a day case to an inpatient if we can't control the nausea and vomiting post-surgery. And this will lead to overnight stays in inpatient beds when originally they were scheduled for a day surgical procedure. So when we think about what makes us vomit, so it's anything that stimulates the vomiting centre. So the vomiting centre is responsible for controlling and coordinating all of the nausea and vomiting reflexes. So it's located within the medulla oblongata of the brainstem. We're going to look at what feeds into this over the next few slides. On the previous slide that looked at what makes us vomit, it was stimulus to the vomiting centre. So the things that can stimulate the vomiting centre are things like the gastrointestinal tract, peripheral pain receptors, the nucleus solaris, which is responsible for controlling the gag reflex, the vestibular system, so that's motion sickness, the cerebral cortex, so that's when you have horrible sights, smells, tastes and things like that make you feel nauseous or induce vomiting. And there's also an area called the chemoreceptor trigger zone. Over the next few slides we're going to look at these in a bit more detail and how they all feed into the vomiting reflex. So if we look at this diagram here, this is some of the things that are going to feed into the vomiting centre to induce that vomiting reflex. So if we start over on the right hand side, we've got the vestibular nuclei. So this is an area that's responsible for coordinating the signals from your inner ear that controls motion and balance. So when we look at these, people that suffer from motion sickness often have issues with their inner ear and they become hypersensitive. So as there's lots of movement that can't be sort of naturally coordinated and controlled, this can make them feel nauseous as a result. So the vestibule of the ear stimulates the vestibular nuclei, and then that stimulates the vomiting centre that induces this vomiting reflex when they have travel sickness. So if you notice on the picture of the vestibular nuclei, there's histamine 1 and muscarinic receptors on there. So these are the neurotransmitters that are involved in communication when the vestibular nuclei is stimulated. So they're the neurotransmitters involved in the transferring of the messages from these areas to the vomiting centre. So these will become more apparent a bit later when we start to think about how we can prevent nausea and vomiting with antiemetics. So another important area within the sort of control of vomiting and our protection is an area also within the brainstem called the chemoreceptor trigger zone, or the CTZ. So the chemoreceptor trigger zone sits outside of the normal blood-brain barrier. We have this blood-brain barrier as a protection to stop the circulating toxins from our blood poisoning our neural cells within the brain. But the CTZ sits outside of that blood-brain barrier, so it is exposed to any circulating toxins. So it's this that's responsible for detecting those toxins, and then when that's stimulated by the toxins, that also communicates with the vomiting centre and induces the vomiting reflex. So One of the things that might cause this or stimulate this are cytotoxic drugs, so chemotherapy drugs. So they're renowned for making people feel awful and have terrible nausea and vomiting. And it's the chemoreceptor trigger zone that would be detecting these agents and then setting off the vomiting reflex. Also, other circulating drugs, so alcohol would stimulate the chemoreceptor trigger zone and induce vomiting if there was excess there. The neurotransmitters that are involved within the chemoreceptor trigger zone is 5-HT3, which is serotonin, and also dopamine 2. So these are the neurotransmitters that are involved in the messages that are either stimulating or coming from the chemoreceptor trigger zone. So the next area that we could look at is the gastrointestinal tract. So our stomach, within the lining of that, has these cells called enterochromaffin cells, and when they detect toxins, they can be stimulated, and they also release 5-HT3 or serotonin. So the way that these neurotransmitters, they then stimulate and communicate with the vomiting center via the vagus nerve. So the vagus nerve has many roles within the body and is often stimulated by various things. When people have fainting attacks, they're often called vasovagal episodes, and often when people have these sort of fainting episodes, they often feel hot, they often feel sweaty, but they're often nauseous. So if you're stimulating the vagus nerve as part of this vasovagal episode, that could then stimulate the vomiting center and would account for this nauseous feeling that they get when they are fainting. Also, if you're having nasty stomach cramps, due to trouble with your bowel, or you've ingested some, got food poisoning, you get those horrible stomach cramps, and again, that can make you feel very nauseous or even induce vomiting from that, and that's all vagal stimulus that does that. Also, cytotoxic agents are very irritant to the gut, and again, that can cause the release of the serotonin, and again, down the vagus nerve, stimulates the vomiting center, and the vomiting reflex is induced from that. So if we think what the vomiting reflex is, or what it does, so before you're about to vomit, you get all of those sort of telltale signs. People often talk about, I get this funny salty taste and excess salivation. So that's kind of our bodies getting ready for the vomit to happen. So the extra salivation is kind of lining your mouth ready for when all of the stomach acids and the stomach contents are about to come out. So we also get contraction of our stomach muscles, a contraction of our diaphragm, and all of these are trying to increase intra-abdominal pressure to try and increase the efficiency of the vomit. The sphincter at the top of our stomach relaxes, so that's opening the valve to allow the vomit to come up, and then all of this is coordinated into the vomiting reflex. So if we look at the neurotransmitters that are part of the vomiting reflex, I suppose, and that communicate with the vomiting center, it's very complicated, and there's about 40 different neurotransmitters that are involved. So some of the most important ones that are there are acetylcholine, so that's with the muscarinic receptors. There's histamine, and there's also serotonin, or 5-HT3. So the drugs that control this are often antagonists to these neurotransmitters, and we'll look at those as we go through. So if we look at the chemoreceptor trigger zone, so this is a group of cells that are situated close to the area of the posterior of the floor of the fourth ventricle, as you can see from the diagram on the right. So it's a very vascular area, and it's situated outside of the blood-brain barrier, as I mentioned earlier. So therefore, this makes it very vulnerable to circulating drugs and toxins. So it's got a very major impact on the activity of the vomiting centre because it is detecting all of those circulating toxins. So the neurotransmitters that are affecting the chemoreceptor trigger zone are dopamine and serotonin, or 5-HT3. So if we've spoken about lots of things that cause vomiting, but we need to look at the risk. What are the risks that increase the chance of post-operative nausea and vomiting? So these can be split into 3 categories. So are they patient risk groups? Is it the surgical procedure? So for example, certain procedures are more risky, or increase the risk of inducing post-operative nausea and vomiting. So craniotomy, so any sort of neurosurgery, because again that's very stimulating to the brain and that can induce vomiting. We've got ENT surgery, so particularly if it's inner ear surgery, or it could induce the gag reflex if there's surgery within the oral cavity. So major breast procedures. So this is, if the having major breast surgery, that can be very stimulating hormonally, and the hormones can then, increase the chance of nausea and vomiting. So we've got strabismus surgery, so that's eye surgery for squints, and again the muscles of the eye have a very strong innervation by the vagus nerve. So if you're pulling on the eye muscles, that's very stimulating to the vagus nerve, so then that could then stimulate the sort of vomiting reflex from there. And also abdominal surgery, so either laparoscopic or laparotomy, they're both high risk surgeries from a post-operative nausea and vomiting point of view. The other category is the type of anaesthesia that's performed. We're going to look at these a bit more in a few slides' time, about different types of anaesthesia that increase or decrease the chances of post-operative nausea and vomiting. So one of the things that puts you into a high-risk patient group is, first one on here we've got is if you are of the female gender. This is particularly prevalent if you're post-puberty, so it's because you have a higher circulating hormone levels. So another thing is if you're a non-smoker, that increases the risk over a smoker. That could be that your body is used to more circulating toxins, so you may not be quite as sensitive to other toxic agents. If you've got a history of post-operative nausea and vomiting in the past, that again puts you in a much higher risk group, whether that's sort of psychosomatic, or whether you are do have extra risk factors. The psychosomatic side of it is that if you've had it before, you almost talk yourself into it again the next time because you're expecting it to happen. So the next people is people that have a history of travel sickness. They have an increased risk, again because they've got that sort of hypersensitive vestibular system within their inner ear, so they're again a higher risk from that point of view. So patients that suffer from migraines are at increased risk. Dehydration can often make you feel very sort of nauseous. If you think of what it's like when you're a bit hungover, you feel a bit nauseous as part of that, and that's often relieved by having plenty of fluids, to increase your hydration. So pain, if you have poorly controlled pain in recovery, that increases your chances of nausea. As the pain response, but also getting on top of that pain, you're probably going to have to use opiates and stuff like that, and they're renowned for making you feel nauseous. So prolonged surgery is another risk factor. So if your surgery is longer than 1 hour and 20 minutes, that has an increased risk of nausea and vomiting. This could be that the anaesthetic agents, as they come into your body over a long period of time, they kind of leach into the fats. This is quite a slow process, but it's also quite slow for them to then come out of the fats as well. So you have the anaesthetic agents hanging around for a lot longer than normal. So the other thing that puts you in a high risk group is if you've had a poor anaesthetic evaluation. So the anaesthetist should be asking questions about your history of nausea and vomiting, and asking you all these questions to decide, are you in the high risk group? And if you are, they could be using prophylaxis to try and reduce your chances of nausea and vomiting. But if you're in the high risk group, the incidence of nausea and vomiting can be up to 80%. That's quite a lot, isn't it? Sort of 8 out of 10 people in the high risk group are likely to have nausea and vomiting unless we do something for prophylaxis. So a way we can decide if a patient is at high risk, there's something called the Apfel Simplified Risk Score. So the risk factors that are involved in the Apfel score is number 1, are you female? Number 2, do you have a previous history of motion sickness or post-operative nausea and vomiting? Are you a non-smoker? And is your surgery likely to require post-op IV opioids? So if you look at the number of risk factors versus the risk of nausea and vomiting, so if you've got none of these factors, you've got about a 10% chance. 1 factor 20, 2 factors 40, 3 factors 60, all the way up to, if you've got all 4 of those factors, you've got an 80% chance of having nausea and vomiting. So on this slide, we're just going to look at some of the anaesthetic drugs that increase the risk of post-operative nausea and vomiting. So you could say that they're emetogenic drugs, so drugs more likely to make you sick. So volatile agents, so any of your sevoflurane, isoflurane, desflurane, they can increase your chances of post-operative nausea and vomiting if they're used, and particularly if they're used for long periods. Nitrous oxide is another. Again, that's quite nauseating. Opioids or opiates, they're renowned for causing nausea and vomiting. So it's things that we can do to try and reduce these. Also, high dose neostigmine, so the reversal of muscle relaxants. If you have to give a second dose of that, if they're partially reversed. The reason for this is neostigmine will increase the amount of acetylcholine that's circulating within the synapse at the neuromuscular junction, and acetylcholine stimulates the muscarinic receptors, so they're involved with as part of the the vomiting reflex and stuff, so that will increase the chances of your nausea and vomiting. So in the previous slide, we looked at anaesthetic agents that increase your risk for post-operative nausea and vomiting. So we're now going to think about some alternative methods of anaesthesia that decrease the chances of nausea and vomiting. So the use of propofol is a good agent if patients are at high risk of nausea and vomiting. Propofol itself has antiemetic properties. So if we can use that, as well as avoiding volatile agents, we're also giving a drug that is good for nausea and vomiting. So this can be done through TIVA, so total intravenous anaesthesia. And by doing that, we can then use no volatile agents and the risks associated with those. So the other thing that we can do is to consider neuroaxial anaesthesia. So can we use spinals and epidurals or regional nerve blocks? And again, all of these things both decrease pain, but also if we as an alternative, we don't then need to give opioids, and again the risks associated with high dose opioids. So neuroaxial anaesthesia is a good technique for people that have high chance of post-operative nausea and vomiting. So up until now we've been looking at things that cause nausea and vomiting. So we're now going to look at how do we stop this. So the main way of doing this is to use antiemetics. So antiemetics fall into various categories. So we've got antagonists of 5-HT3, which is serotonin. We've got antagonists of the dopamine receptors. We've got antagonists of histamine receptors. We've got corticosteroids. We've got antagonists of the muscarinic receptors. So these are the ones that are stimulated by acetylcholine. And we've also got antagonists of neurokinin 1, which is substance P. And substance P is a neurotransmitter that's involved in pain as well as nausea and vomiting. So antagonists are drugs that sort of compete and reduce the effects of these neurotransmitters, therefore slowing down or reducing the signals and the communication between each of the areas involved in the vomiting centre. So over the next couple of slides we'll look at these individually, and we'll look at the types of drugs and the names of the drugs that fall into these categories. The first ones that we're going to look at are the 5-HT3 antagonists, so the serotonin antagonists. So the names of those are ondansetron, granisetron and daltestron. So they all are 5-HT3 antagonists. So ondansetron is probably one of the most commonly used antiemetics. So what it does is it works at the chemoreceptor trigger zone and the vagal afferents within the GI tract and tries to stop those messages getting through to the vomiting centre. So sometimes they say that the anti-vomiting is better than the anti-nausea effects of ondansetron. So it's more likely it will stop you being sick, but you may still have some degree of nausea. So it has about a 4-hour half-life. So after 4 hours, only half of the drug is still within the circulation. This means that you have doses throughout the day. So all three of the ondansetron, granisetron and daltestron have fairly equal efficacy, and it will just depend on what your pharmacy commission or your trusts are using at the time. So all of these serotonin antagonists, they'll have some side effects. So they can give you a bit of a headache, sort of muzzy feeling head. They can give you constipation because they may slow down the gut motility a bit. And they also can cause something called prolonged QT. So what prolonged QT is some of you hear of athletes that just suddenly drop down dead, often Afro-Caribbean in origin, and they have this condition called a prolonged QT. So what that is if you look at their ECG, between the Q wave and the T wave, which is the cells repolarizing, they have a longer than normal distance. So sometimes it will get to the point that this distance becomes so long that their heart cell or the myocardium doesn't repolarize to allow it to beat again. So you can give up to 16 milligrams of ondansetron a day. And what they found was people were giving 8 milligrams as a prophylactic dose, and they found that they were having an increased risk of this prolonged QT. People that had it was making it worse, and it was giving them arrhythmias or worst case scenario that they could have this sudden death. So it was then shown that we shouldn't be using 8 milligrams as the prophylactic dose. We should only be using 4, so that's been updated within the BNF as a result of that, because the more it was used, it became quite trendy to give 8 milligrams because it seemed to work, but the risks of this had to be outweighed the benefits. So 4 milligrams is the recommended prophylactic dose now. The next ones to look at are antagonists of D2 or dopamine. So examples of these are stemetil or prochlorperazine, as its generic name is. So there's droperidol, haloperidol or metoclopramide. They're all antagonists of dopamine. So they work on the receptors in the chemoreceptor trigger zone, and they have some side effects. So droperidol and haloperidol can be used as sort of antipsychotics, and as a result of that they give a degree of sedation or possibly some hypotension. Another side effect of dopamine antagonists are these things called extrapyramidal side effects. So they can give you this restlessness, or you can get involuntary movements caused by them, so they get these funny jerky movements as part of it. Another thing is something called spasmodic torticollis. So this is where the muscles of the neck go into spasm. So their head becomes like fixed over to one side as the sternocleidomastoid muscle in your neck goes into spasm. Another thing that they, as part of these extrapyramidal side effects, is something called an ocular gyric crisis. So if you find your patients wake up in recovery and their eyes are kind of spinning around and having weird, strange, jerky movements, or they get fixed up into the top corner or something like that, it's worth looking back at their drug chart to see if they've had any dopamine antagonists, because these all fall under these umbrella of extrapyramidal side effects. So, if that's the case, you'd obviously go back to your anaesthetist and let them know that this has happened so that they can investigate further. The next ones to look at are antagonists of H1 or histamine. So the common ones with this is cyclizine or promethazine. So they work on the histamine receptors, particularly within the vestibular nuclei. And because it's the vestibular nuclei, they're quite useful for sickness caused by opiates and general anaesthesia, but also motion sickness, because motion sickness, if you remember, is overstimulation of the inner ear or the vestibule, and that stimulates the vestibular nuclei. So by having an antagonist of the histamine, it can hopefully reduce or block some of these messages. And morning sickness, it's good for that too, because morning sickness has an effect on the vestibular nuclei. So the excess of hormones can be quite stimulating for that. So cyclizine is the preferred drug of choice for antiemesis. So people that have hyperemesis, so excessive morning sickness during pregnancy, are often prescribed cyclizine because that's the drug that's licensed for it, and because it works on the areas that are most stimulated by the hormones. Another condition where cyclizine or promethazine is used for antiemesis is Meniere's disease, and that's a disease that causes blockages within the vestibule of the ear that controls the balance. So again, because they're having issues with that, cyclizine or promethazine work very well for Meniere's disease. So corticosteroids are sometimes used, or fairly often they're used as they have antiemetic properties, particularly dexamethasone. Dexamethasone seems to be the most commonly used corticosteroid used for antiemetics. The thing with the dexamethasone on the slide there, I've put do not give to awake patients on induction. If you give dexamethasone as a bolus, it can give this really quite pronounced sort of perineal burning, and there have been case reports of female patients have felt that they're being interfered with as they're drifting off to sleep, because they get this sudden warmth or burning in their perineal area. Or they say that they can sometimes get sort of clitoral arousal feeling, from as the dexamethasone goes there. So there have been case reports, like I say, where they've felt that they were being touched as they drifted off to sleep. So it's really important not to give it to patients until they are properly anaesthetised, because this is quite a recognised side effect. So side effect wise, there aren't many really in sort of small infrequent doses. They say that you should use it with caution in diabetic patients because it can increase their blood sugar levels, but in the sort of small infrequent doses that we give, it doesn't have that much of an effect. It has quite a slow onset of action with regard to the antiemetic effect, so it's best if it's given early, so shortly after induction, but make sure that the patients are properly anaesthetised before you give it, because they may have those that horrible burning sensation. So if we just look at the last couple, so Another type is anticholinergic, so they're antagonists of the muscarinic receptors. So scopolamine is one of the most sort of common ones of those. Scopolamine used to be used in sort of end-of-life care, where patients were starting to lose their swallowing reflex, but they were still salivating. So the reason it was used is the side effects of these anticholinergics gives you a very, very dry mouth. So, it stops the saliva production, and it can give you some visual disturbances or sort of dizziness feelings, as a side effect. So another one, another type is antagonists of neurokinin 1 or substance P. So apretan is one of those. And this is not used particularly very often in theatre, or I've not seen it used, but it's often used when patients are having chemotherapy as an adjunct as part of that, and it works on the sort of final common pathway in the vomiting centre, so stops it at that point. We've looked at pharmacological methods of antiemetics, but an alternative to that is acupuncture or acupressure. So if you have a look at your wrist, you've got your creases in your wrist, and if you go put 3 fingers above that, and this measurement's known as tu chung in acupuncture, you have 2 tendons in the centre of your wrist, and 3 fingers up from the wrist creases between those 2 tendons is the P6 acupuncture point. So if you were to massage here, if you're feeling nauseous, that can stimulate the P6 acupuncture point, and that can help with the nausea and vomiting. When you have morning sickness bands or travel sickness bands, that's what they're doing, is they're using this P6 acupuncture point or acupressure, as it's just the little marble that sits over the top of it, and that can be quite good for travel sickness or morning sickness. I've worked with an anaesthetist that patients that were high risk, he used to pop an acupuncture needle in this point on both of their wrists before they went to had their anaesthetic induction, and he used this in patients that were in high risk group, and he found that he had quite good results from that. So in summary of what's been discussed in the slides, so it's really important that patients should be properly assessed prior to surgery. There should be a risk assessment done, and as part of their anaesthetic evaluation, because it can highlight who is high-risk patients, and then prophylactic measures can be put in place if required, whether that be a pre-med or making sure that we use a multimodal approach to their antiemetic treatment. Attack it from different angles, use different types of drugs. 5-HT3 antagonists, dopamine antagonists, histamine antagonists. You go at it from different angles. Can we use alternative anaesthetic methods, so TIVA or neuroaxial anaesthesia in these high-risk patients, because that's going to minimise the use of opioids and decrease the risk. So all of these things should be taken into consideration.